So these are the two compensatory responses. One is respiratory, where there is hyperventilation, and second is renal compensation. So laboratory diagnosis, uncompensated and fully compensated. First, I think pH will be low, uncompensated. The bicarbonate will be low. So if PCO2 is normal, then compensation is not started. So as a result, the ratio of HCO3 by H2CO3 is less than 20. Compensation start. Once it is fully compensated, the pH will return to normal. HCO3 usually it is already depleted, so it needs some time for replenishment. Okay, so HCO3 will be low only. It won't become normal suddenly, but due to hyperventilation, the PCO2 will be, carbon dioxide will be removed. Okay, as a result, PCO2 level will be low. Since both are low, the ratio will become normal. So then I think we can say that acidosis is compensated. Okay, clear? So laboratory diagnosis, at least you remember these things. Forget about fully compensated. So if you ask laboratory diagnosis, you have to write minimum. pH is low, bicarbonate is low, PCO2 is normal, and this thing. Okay, the ratio is less than 20. So this is about metabolic acidosis. So next we will move on to the metabolic alkalosis. Before that, one more term known as paradoxical aciduria. No need to note on this. This is for PGs, it's important. So I told that potassium and hydrogen will exchange with each other. Okay, whenever the acid load is more, potassium will be taken inside and this will be removed. Okay, what is that? Acid will be removed. In the reverse way, if potassium is low, there is increased excretion of acid won't be taken. So this can result in urine becomes acidic. These are some of the conditions where it is in Cushing syndrome, cortisone therapy, and this thing. You can skip this one, it's not very important. Metabolic alkalosis, there is primary excess of bicarbonate either due to loss of acid or retention of alkali. So two types are there based on a treatment with sodium chloride. Chloride resistant metabolic alkalosis. If the patient responds to chloride treatment, chloride responsive alkalosis. If he is resistant, if he is not responding, then chloride resistant alkalosis. So what are the causes for chloride responsive alkalosis and chloride resistant alkalosis? So these are the causes for chloride responsive. Again, prolonged vomiting, nasogastric aspiration, upper GIT obstruction. So in this condition, for example, vomiting, there is loss of H plus, loss of Cl minus. Okay, so that lead to hypovolemia. Once there is hypovolemia, what happens? Something will be activated. What is that? RAA, renin angiotensin system. Okay, so aldosterone. How that lead to alkalosis? Next slide I will show. Just you can see the mechanism. Once there is loss of HCl, there is loss of H plus. So this can lead to alkalosis. So once there is hypovolemia, activation of renin angiotensin system, leading to increased level of angiotensin 2 or aldosterone. This can lead to metabolic alkalosis either by increasing bicarbonate reabsorption or by excreting secretion of H plus and K plus. So these are the two mechanisms through which this hypovolemia can lead to alkalosis. How vomiting lead to alkalosis means at least loss of HCl. Once loss of HCl, acid load will be lost. Acid load will be reduced, leading to alkali accumulation. So biochemical changes, there is urine chloride will be less than 10 millimoles per liter due to increased reabsorption of chloride, and usually there will be hypokalemia. Okay, that mechanism already I told. hyperkalemia will be there. Any alkalosis, hypokalemia will be there. Okay. Suppose in your exam they ask list 2 conditions where hyperkalemia is seen. So just remember metabolic acidosis. So what are the causes for metabolic acidosis you mentioned? That will become cause for metabolic hyperkalemia. Similarly, metabolic, what is that? Hypokalemia causes, metabolic alkalosis. 2-3 causes you remember, then you can write. So chloride resistant alkalosis, again hyperaldosteronism and Cushing syndrome. Here sodium will be retained and there will be loss of acid as well as potassium. I think this mechanism you know already. So here urinary chloride will be more than 10 millimoles. This is one way we can differentiate between chloride responsive and chloride resistant alkalosis. If you measure urinary chloride less than 10 millimoles, chlorine responsive alkalosis more than 10 millimoles, okay, chloride resistant alkalosis. So what will be the compensatory mechanism here? Just you can think, it's just opposite to your acidosis. Renal mechanism there, not hypoventilation. That is one, okay, respiratory this thing. What happened to H plus excretion? It will decrease. Bicarbonate reabsorption, it will increase, okay. Bicarbonate reabsorption is increased or decreased? Okay. Bicarbonate has to be excreted. Okay. Yeah. Decrease. So iatrogenic causes means any drug intake can lead to alkalosis. Any alkali intake, diuretics, massive blood transfusion. What is the link between massive blood transfusion and have you donated blood anytime? Only one. Have you seen the blood bag? Okay, so that blood bag contains citrate. Okay, so if citrate will be mixed with this thing, excess citrate can be converted to bicarbonate. So because of that, alkaline will be more. Okay, so citrate metabolism, bicarbonate formation will be more in massive blood transfusion, leading to alkalosis. Antacids have you heard? Antacids that you are taking. Okay, so for acidity they are using. Okay, so it suppresses acid production that can lead to alkalosis. And finally, milk alkali syndrome. This is a old term for acidosis. What is that? Acidity. They used to treat with milk because of soothing effect. Those milk, this thing contains this alkali that can lead to, but it's very rare. So these are some of the clinical features. Okay, tremors, cramps, then hypoventilation, tachycardia, other thing. So compensation, there will be hypoventilation, respiratory compensation, and renal excretion of H plus will be reduced. So acid will be, and reabsorption is of bicarbonate is reduced. Again, lab diagnosis, what will be the feature? What happens to pH? pH will increase, bicarbonate will increase. PCO2, why PCO2 will decrease? Uncompensated PCO2 will be normal. Okay, so pH will increase, bicarbonate will increase, your PCO2 will be normal, so ratio will be more than 20. But once compensation starts, there will be hypoventilation. Once there is hypoventilation, carbon dioxide retention, as a result your PCO2 will be more. That's why the ratio will become 20. Okay. Respiratory acidosis will finish. Okay, another 5 minutes. Alkalosis next class we can do. Or you want break now? Huh? Whatever you tell. You want break or you will take up acidosis? Continue, just 5 minutes. Acidosis, there is primary excess of carbonic acid, that PCO2 will be more due to depression of respiratory center or due to defective elimination of carbon dioxide. So depression of respiratory center, I think already you are aware. Head injury, morphine, barbiturates, tension pneumothorax. What do you mean by pneumothorax? Air will be accumulated in thorax. Okay, tension pneumothorax. Okay, that way any injury, any chest trauma, tension pneumothorax will be there. Once pressure is more, it can lead to other complications, so it has to be relieved. What are the conditions where the carbon dioxide expulsion will be defective? Again, physiology. Any respiratory disorders. Okay, so COPD, asthma, so many conditions are there. So emphysema, asthma, pulmonary edema, in these conditions, the expulsion of carbon dioxide is defective. So there is accumulation of retention of carbon dioxide leading to acidosis. Okay, same mechanism which you have read already. So compensatory response here, respiratory compensation will not be there since it's respiratory acidosis. There will be compensation by buffer mechanism and kidney. So buffer, usually the carbonic acid is buffered by hemoglobin and protein buffers. So bicarbonate will be spared. That may be one of the compensation. The second, excretion of acid will be more, similar to your metabolic acidosis. Bicarbonate reabsorption will be more. As a result, bicarbonate level will be increased in fully compensation. Whereas in uncompensated state, the bicarbonate will be normal. So some of the clinical features: hypotension, reduced respiratory rate, weakness. Okay, laboratory diagnosis you can note down. So pH will be low. In the uncompensated state, bicarbonate will be normal. PCO2 is high because hypoventilation, carbon dioxide retention, and ratio will be less than 20. Whereas once compensation starts, once it is fully compensated, pH will be normal. The bicarbonate will be high. Why bicarbonate is high? Because absorptional reabsorption will be more. Second reason is bicarbonate will be a sparing effect. That hemoglobin and the protein buffer will act. Bicarbonate will be spared. So the bicarbonate level will increase. PCO2 again it will be remain high. It will take some time to reduce. As a result, the ratio will become 20. Okay, so this is the lab diagnosis of respiratory acidosis. So we'll stop at this level. Anything you didn't understand, any causes, mainly causes will be asked and laboratory diagnosis will be asked. Okay, sometimes if it is asked as a part of main question, they will ask compensatory mechanism. So these are the three aspects in metabolic acidosis, alkalosis, respiratory acidosis and alkalosis. Clear? And anion gap will be one more question. Definitely they will ask to calculate. They will give the values and they will ask to calculate how much anion gap is present. Okay, next class we will continue.